We are planning for upper full mouth rehabilitation. Only few teeth remaining. First we will see the panoramic view and we will see the sinus. You can see the right side sinus. Sinus severe expansion downward and anteriorly also. Especially the sinus expansion is more severe on the left side. The remaining alveolar bone height is very less here compared to the right side. And also the tuberosity sinus expansion also we have to check the feasibility of pterygoid. We will see the cross section, anatomy of everything. We are planning for a tentative 6 implants. First we will plan the right pterygoid. So this is the anatomy of the right pterygoid. Tuberosity, sinus wall, humeral notch. If we start from the socket, then we have to tilt it like this. A lot of tilting is needed. If we start from the slightly from the crest of the socket, less tilting is needed. So these are the two options we have available. First we will check the starting from the socket area and we will tilt distally. Okay, there is severe sinus expansion distally. Usually the sinus expansion is more on the buccal aspect. This is the buccal aspect. So stay close to the palatal aspect. We can avoid the sinus. So the length is almost like 18 mm. We can place a smaller diameter 18 mm implant. Smaller diameter implant, it can engage easily, otherwise the implant can slip into the sinus like this. If the implant apex is very wider, instead of going into the osteotomy, it can tilt into the, instead of going like this, it may go into the sinus. So displacement of implant, misdirection of implant toward the sinus is more on this situation. To avoid that, you can start the implant from the crest, slightly some more distal and start it. Even though it looks like the sinus, the implant is partly into the sinus, actually it will be palatal. The implant will be palatal, the sinus will be on the buccal aspect. So this anatomy we should understand. Sinus expansion, even though it looks more severe on the pano view, it will be actually buccolingual, it will be more on the buccal aspect. So palatally there will be, you will get bone without the sinus invasion. In severe cases, the sinus invasion will be on the palatal aspect also. This we can analyze only by CBCT. So the right side is challenging but doable. If we don't analyze this challenge and if we start straight away, we may end up in engaging the sinus floor. We may engage the implant like this. We will place 18 mm implant, but only 6 mm implant will be in the alveolar bone. Other implants will not be in the pterygoid bone. It will be into the maxillary sinus, and we won't get stability, and we will think we are not on the pterygoid is, we won't achieve proper pterygoid implant. So this challenge we have to analyze before. Taking a IOPA during pilot drilling is essential to make sure it is not going into the sinus, to make sure it is correct amount of distal angulation we give. Now we go to the left pterygoid, which is more challenging. It is almost like next to impossible. Okay, so the chances of placing a pterygoid implant in this situation is very less, almost 10%. Not all pterygoids we can do. There are some extreme situations will be there. This is one such kind of situation. You can see the sinus is very close to the tuberosity and also to the amular notch area. So what is the distance between the sinus and the amular notch is the more important one. So here there is no distance is there here. That is the thing we are worried about it. And not only that, the remaining tuberosity bone also is very poor quality. It looks like a sinus thickening. So even if we start from the socket area, you can see the implant is looking entirely into the sinus, the middle section. We will see the CBCT cross section. So on the right side, if you see, the sinus is only on the buccal aspect. Here the sinus is extensive both on the buccal, palatal and also towards the crustal. So placing implant in this situation is extremely tricky. There is more chances of implant slipping into the sinus, not engaging the pterygoid bone. If at all we are placing, we can choose a 3.5 into 18 or 20. If you are getting stability, that stability will be from this poor quality cortical bone and this 3 to 4 mm of pterygoid bone, which may not be sufficient. There is high chance that the implant may not engage here, because after our implant coming out of the sinus, we have to exactly catch the osteotomy. Sometimes it is possible, sometimes it is not possible. So placing here is quite challenging. So we should have a plan B. If we cannot place pterygoid, what is our next plan? We have to look at it. Okay, in all angles this pterygoid looks very challenging. The two placing a conventional implant is risky. There is a risk of implant slipping into the sinus. Now we will see the anterior pre-maxilla, which is the most critical now. If we can achieve a all-on-4 with favorable cantilever, we don't have to worry about pterygoid on the left side. So on the left tilted we will plan first. So almost it is in the canine area. Distal to canine is our exit point. So the left tilted implant starts in the first premolar. Okay, and there is severe sinus expansion here. There is no nasomaxillary buttress here, so we have to engage the NC point, nasal corner point. So in this buttress is fully maxillary sinus. Only this bone is the area where there is no sinus expansion. Till here it is sinus expansion. So how to find this? Just bring virtually the implant out. We can see the implant is almost like near the nasal corner here, just above the nasal corner. Okay, so we can start the implant from the first premolar, and we can give one single tooth cantilever, second premolar, and when patient comes for a permanent, we can give a molar cantilever also. In the meantime, plan C is placing one sleeping implant here in the molar area, just anterior to the gate. Very short implant with mild indirect sinus lift, 7.5 mm, 4 mm diameter. There is difficult to load because of low stability, but we can integrate within the permanent processes after 4 or 5 months. So this is another backup plan. The third right tilted we will plan now. Right tilted is starting from, it is from second premolar. It's almost this is canine, this is first premolar, this is almost from between first and second premolar. Here we don't have to worry about cantilever because pterygoid is possible here. Here also the target point is almost near the nasal corner, just distal to the nasal corner. Almost like 18 mm implant we can place. So the challenging part is the anterior axial implant. there are two challenges. One is a very thin ridge and labial concavity, and there is defect on the left side, the 2-2 and 2-3 area. So one option is to go for only one implant in the midline, and another option is to go for 2 implants. So we will plan an axial implant first. So severe labial concavity, very thin ridge, palatal approach, little bit tricky. So you can try the M technique also, just tilt distally. You can get some more little good bone there. About 14 mm bone we are getting. If you go straight, we will be getting 12 mm. Even up to 13-14 mm length is available if we tilt it medially. Almost 13 mm, 14 mm implant is available. So by tilting slightly medially, we can increase the length and engagement. Left side axial is very short one, only 8 mm implant. So we will try tilting either medially or so towards the midline also we can tilt. Of course, it will invade the nasopalatal canal. We can insert a 13 mm implant, or we can tilt and distally. But if you go distally, there is a defect area is there, so better we tilt slightly toward the midline. Okay, so anterior to axial implants we cannot place axial. It will be like some tilting so that we can get some good bone and to avoid the defect. Okay, and we will plan for some backup implant in 7 area. So there is 7.5 to 8 mm bone is there. The bone quality is also good. We can keep this bone as a backup option, or we can put a sleeping implant for future use. So this is overall this is a tricky situation. Because of two situations, the left pterygoid is difficult, and anterior labial concavity, bone defect, thin ridge. These are all things which makes this case challenging.